She started Facebook first.
Hi, guys, and welcome to our donor IVF and surrogate Q&A. We're actually on Instagram tonight and Facebook Live, and I'm here with our panel of experts. I want to let you guys know that we are here to answer your questions, and I'm going to actually be live on Instagram, kind of setting up for right now, and I'm going to be joining Dr. Ellen Wood as well on our Instagram. So
super.
All right. So welcome, everyone.
Okay. All right.
And we'll be going on in just a second here. Let's see here.
So donor concierge that went on me. So hi, I'm Dr. Ellen Wood. I've gone live on my Instagram at Dr. Ellen Wood, and I've also gone live on IVFMD. So what we're planning to do is that donor concierge, you can join me on IVFMD. You can, I think that was the plan.
Yes.
On IVFMD?
Yes, we're all going to be multitasking here a little bit with our comments. And so we're each going to be listening to our panel today, and we're also going to be answering your questions at the end. So I'd like to introduce our guest today. It's Dr. Kenneth Gelman of IVFMD and Dr. Ellen Wood of IVFMD. And we also have with us a special guest for Donor Concierge. And I'd like to introduce Gail Sexton to you. And she'd like to also say a few words about how women and surrogates are, actually finding help through their services as well as through egg donation requests. We're also going to talk about sperm donation as well, and we're going to try to get all your questions answered at the very end. So hang in there with us. We know that it's been, we're actually, I'm Farrar Duro with Florida Complete Wellness. For those of you who don't know me, we've actually been doing Facebook Lives and Instagrams every Wednesday night with Dr. Ellen Wood. And we're here tonight because we actually know that, there's a lot of questions surrounding our patients who are considering a donor cycle, or they're trying to get more information on that. And we haven't really addressed this so much. As we know, there's so many ways to start a family, and I think that it's important to acknowledge all of them. So I'm going to actually see if I can get Dr. Ellen Wood on our Instagram. If not, we're actually on Facebook as well. And also you can view this on IVFMD's on the Instagram page as well. So welcome, everyone. Thank you so much for being here tonight. I know there's a lot going on. Our hearts are very heavy, and we're with those right now who are struggling across the country. And we want to also tell you that we're here for you as well. I hope that we can answer some of your questions regarding this issue. And I'd like to have Dr. Ellen Wood start out tonight to tell us a little bit about how she handles third-party reproduction issues in her practice.
Okay. Dr. Duro, were you going to join me on my Instagram?
I'm actually live on mine, so if you could join me on mine, that would be great.
I'm not sure how to do that.
Oh, okay. You might have to end yours and go into mine.
Okay.
So we're
okay.
But
let's see.
If not,
okay, that's fine. Let's see. And now, okay. This is a work in progress. Okay.
Yes, we're actually triple streaming today.
Yeah. So we're just like, there we go. Live, and I'm joining her. How do I join you?
And you can just request. Oh, there you are. Okay. So.
All right, okay, cool. All right. Anyway, this is a technological feat, but it's pretty cool. So this is a different subject that we really don't address in kind of our Q&A because it's something that it's a little bit nichey. There's definitely a point in the.
Okay.
There we go.
There you go.
There's definitely a niche in the infertility population that needs this service, and it's kind of a mystery to a lot of people. And so when we try to introduce the subject, sometimes it's very difficult to understand. So you're telling me I can't get pregnant with my own egg, but I can get pregnant. So what does that mean? So what that means is that your uterus is essentially functional throughout your life, even if your ovaries have kind of given up on you and they're no longer able to provide you with healthy eggs. And so what we can do in order to get your uterus pregnant is we can use an egg from someone who's younger, or if you froze your eggs at a younger age, we can use your own eggs. We can use anonymous donors, we can use known donors, we can use fresh eggs, we can use frozen eggs. Where's the echo coming from? I'm not sure. I've turned down all the volumes on everything.
Okay, I think it's getting a little better now.
So
Okay.
just have the echo taken care of?
Yeah, I think so. I'm sorry.
Every volume of mine is down.
Okay.
Yeah. Mine too.
Okay. So again, sometimes it's a confusing subject when we're talking about it, because it's kind of a paradox. It's like, can I, doctor, can I be pregnant, or can I be pregnant? So that's where using, again, either your own eggs frozen at a younger age, or using eggs from someone younger. I still feel an echo. So you really hear an echo?
A little bit of an echo, yes. Well,
I'm not. We have to stop my Instagram here, because I think that's where it's coming from.
Yeah, it might be the Instagram, but
yeah.
Okay, well, we can still hear you. We're still
that one wasn't. I don't think that one was that. That was the echo, I think.
Okay.
The 3-person thing. I think try to fix that. All right. So anyway, that's fixed by now. So anyway, so basically, what we do as doctors is we assess a patient, we take a couple as far as they can go. And again, obviously your own eggs are ideal. I mean, that is what we're looking to accomplish. But in some cases, we get to the point where, unfortunately, this is no longer a possibility medically. And so therefore, the recommendation from the physician is that your uterus is healthy, your husband's sperm is fine, everything else looks good. We just need an egg that is younger. And unfortunately, as we age, our eggs, lose their vigor, and we don't have, Botox for eggs, and we don't have hair dye for eggs. I mean, we just have no point at, we have no means currently to make an egg from someone who is older or in early menopause, make that egg healthy. So therefore, in order to be pregnant, we need to use a younger egg. So what our job, and what I was supposed to talk about, this evening for a couple minutes, is basically once we make that jump and say, hey, this is what you need, what are the requirements, okay? And a lot of patients who've already been going through IVF process and now have transitioned over into, putting to sleep the dream of using their own eggs and now moving on to using an egg from someone else, basically, they're usually screened already. So we need a normal pap smear. We need a normal mammogram. We obviously need normal blood work. We screen all of our recipients for diabetes. We screen them for high cholesterol. We make sure that they don't have any chronic illnesses that aren't controlled, hypertension, things like that. We try to optimize weight. And then again, we did this when we were using their own eggs as well. So a lot of those patients are already prepped and screened. But once they move on to the donor process, what is involved is several consultations, and it varies depending on age. So one of the consultations that we have is with the psychologist. And psychology is very, very important in understanding exactly what is going on. And so the way I think about it from a psychological standpoint is that, again, this is a couple who are trying to have a baby, okay? And the couple themselves want to contribute to having that baby. So the husband is contributing the sperm, okay? The wife is contributing her uterus and carrying the baby. And then so, the couple chooses the egg together. So everybody contributes to making this family. Making a family is our goal, okay? It's not ideal. Again, our primary goal is to try to use your own eggs. But again, in many cases, our goal is family, okay? And we create families in so many different ways. We create families, via regular treatment, via in vitro, via egg donation. We create families also, with surrogacy. The patient is not able to carry her baby by herself. We create families, again, we refer to adoption agencies. So there's a multitude of different ways, but our goal as reproductive specialists is to make families and help patients create those families and complete their families. So we screen you, okay? So first off, psychology, making sure you understand that genetically, although you're carrying the baby, okay, the genes are that of the egg donor. And we try again to match you with somebody with similar physical characteristics, sometimes similar personality. There's many different ways to choose a donor, and that is again what Donor Concierge is going to go into a little bit later on how they help make that perfect fit for you. But as a doctor, I want to screen you before we send you to the egg donation department, to a service to try and find you the eggs, to make sure that once you are healthy, so you get the eggs, bam. We get you through, we get you pregnant. It's usually, in my opinion, once we clear you and say you're psychologically healthy, you are medically healthy, your uterus is in tip-top shape, everything looks good. Once you find those eggs, 6 to 8 weeks, you're pregnant. And the great thing about this process is the unbelievably high success rates. 3 out of 4 times it works. And then if it doesn't work the first time, many times we'll have extra embryos, and then we can go and it'll work with an extra embryo, because we are being a little stingy with our donor embryos right now. So we used to be a little bit more liberal in the past about replacing more than one embryo, but in the last year and a half, we have really decided as a group that one embryo is all we should replace, especially using an egg from someone in their 20s, because our goal is for you to have a healthy baby. And although twins are wonderful, they can be very difficult on a woman, especially if she's in her 40s or her late 40s body. And there's multitude of pregnancy complications occurring. So single embryo transfer is really what our practice has been doing since, religiously as of January 2019. But again, this is for the health of the patient, the health of the babies, to decrease prematurity and improve baby health. So this is something we're committed to. But so I screen you, whether you're screened from your previous IVF or whether you're just showing up at 45 and you want to have a baby and you realize that your eggs are no longer going to do it for you, then we'll send you through all these screenings. So under 45 and over 45, we have a little bit different, algorithm as far as screening. If you're under 45, it's the Pap the mammogram and the general health screening. If you're over 45, what the screening is going to involve is, in addition to the psychologist, we make you sit down with a maternal fetal medicine specialist, and they review with you all the potential complications that do increase. Okay, patient gets into their 40s, and we have you also be cleared by a medical specialist, preferably a cardiologist, because as we get older, unfortunately, heart disease becomes more prevalent, and our whole idea is to help you have a baby, not kill you. And pregnancy is the biggest stress that a woman can ever have on her body, with the blood volume and the increases in that. And so therefore, we need clearance from, again, preferably cardiology, that says cleared for pregnancy. Okay, I received a screening today from a 45-year-old patient, and the clearance read screened for procedure. Not quite. Procedure, me doing a minor surgery on you and you going through 9 months of a pregnancy with tripling your blood volume, it's a little bit different. So we make sure that a medical specialist, again, clears you for 9 months of pregnancy and then subsequent delivery. So this is very, very important, because again, I stress this to all my patients, our goal is to help you get pregnant, but not kill you. And I have definitely diagnosed a lot of underlying heart disease, and we've diagnosed a lot of underlying medical conditions in patients who, came to have babies and felt they were perfectly healthy. So this is something that we are very attuned to as well. And we don't like to ignore these factors, because a good outcome is what everyone is looking for. A singleton pregnancy, a full-term birth, a full-term pregnancy, a healthy mom, a healthy baby, a healthy family. And that's what we're looking for. So I think maybe my 10 minutes is up. My goal tonight was to talk about, again, that pre-screening that you have to go through. And then once we clear your uterus, we do a water ultrasound, we do an endometrial biopsy, sometimes we do a hysteroscopy. Once that's cleared, you are free to go out and pick those donors and find those eggs. And again, once you've got them, bam, our job is to get you pregnant. So thank you so much for listening, and hopefully maybe able to answer some questions after our other speakers talk. And feel free to follow me at Dr. Ellen Wood on Instagram. Thanks.
Oh, thank you so much. That was super helpful. And I know on our Instagram, you might not be able to see Dr. Whitnell, our
I know, I tried.
but
Yeah.
you'll definitely hear her. That's who's talking now. And also tomorrow night we'll be back as well for an Instagram Live, our weekly Q&A. So I'd like to also talk a little bit about what we do. And that one is basically just preparation for a cycle, whether it's a donor egg recipient cycle, or if you're a surrogate as well. And I think that we'll talk about surrogacy later on tonight. But when, from an acupuncturist perspective, we do reproductive acupuncture at Florida Complete Wellness, and we look at how can we help you have a better cycle. And sometimes we equivalate, like we talked about, Dr. Wood brought up this point before in our Q&A, that we can look at the uterine lining as like a soil, like rocky soil. If it's not so good, sometimes we need to actually work on, making it better. And that's what acupuncture can do sometimes, is work with the blood flow. So we're not really focused on ovarian blood flow and that sort of thing. We're looking at what we can do to help the lining. And a lot of times when patients have the borderline lining, or they just need a little bit of help, we've seen acupuncture make a difference with that. So we look at improving blood flow, also improving stress as well. And we know, like, just getting through a cycle can be really difficult. Sometimes, the weight, and then also the high cortisol levels and the stress that comes with that. So if we're able to help that patient get through, and also help, we call, actually after the transfer as well, doing acupuncture during that time, and also working with a patient. If they're local, we can work with them for the first trimester as well. I think that it's very helpful. We do preventative points to help with nausea, vomiting, and we can also look at if they're having back pain, if they're feeling fatigued, any of those things as well. Acupuncture can be quite helpful for that. We don't only just do acupuncture, though. It's actually a whole person treatment. We look at what things can be helpful from a food therapy perspective. We also look at that person individually, constitutionally, to see if the things that they're choosing to use as far as herbs, supplements, any of that prior to are beneficial. And typically we're not recommending herbs if a patient is about to go for a transfer, obviously. And, the reason is we actually use Chinese herbs earlier, and much earlier, maybe 3 to 6 months prior to a medicated cycle. So for some of our patients who are out of town, they might just actually come in for acupuncture just during the transfer, which is okay, but we actually prefer to see patients 4 to 6 weeks prior, at least 6 weeks we try to. And that's based on recent research that has shown that a higher pregnancy rate is usually, and we know donor cycles have very high pregnancy rates, but even higher if we can actually work with the patient a little bit beforehand on certain things like blood flow, circulation, stress, and all that. So that's usually how we help with acupuncture. I think that it's important to also know that we're trying to be thoughtful of the stress response. So if someone is having a lot of anxiety regarding the procedure itself, and have been through many things to see, what's going to happen, I'm not sure if this is going to work, that sort of thing. It can be a calming thing to also work a little bit on the nervous system, and working with the sympathetic nervous system. So acupuncture can work on the fight or flight response, and we work on trying to help hopefully flip the sympathetic nervous system back into parasympathetic mode. So we'll be actually able to help with even stressors that are external, that are not ever going to go away. Perhaps we can actually change the way your body responds. And so it's still there. The stress is still there. The line's still chasing you, but you're actually dealing with it in a better way. And so that's really how we work with that. And we have worked with surrogates as well. So actually how that works is the patient actually calls and asks for acupuncture during the day of transfer for the surrogate. So we actually would meet them at the transfer, and as long as the clinic offers that service, we'll be able to do the acupuncture protocol that we use, that is based on research done and published I mean, about 12 to 14 years ago. And basically it's showing that we do a acupuncture treatment 30 minutes prior to the actual transfer. And then we do another treatment right after. So we try to work on, again, the same concept with that, helping everything kind of relax a little bit, help with blood flow, help with stress levels. And then we also, if they are a person who is in town, we will see them about 4 to 5 days after the transfer as well. So I know IVFMD does provide acupuncture on site during transfers for their patients. And you have to just check if you if you would check with your individual IVF center to see if that's offered as well. So, hopefully that has been helpful if you are trying to contemplate like the timing, if you're going to do acupuncture, if you're not, and why that might be helpful if you're doing a donor cycle, or if you have a surrogate and you're thinking about perhaps, trying to book an acupuncture visit for your surrogate as well. Definitely we are here to support you with that. So, all right. So Dr. Gelman is up next, and we're going to hear from him about actually donor sperm. And I think this is fascinating to me because we do have patients that are, using donor sperm for different reasons. And maybe you can elaborate a little bit on what kind of things that you look for at that.
Yeah, thanks, Farrar. When IVF came out and, the process of ICSI, ICSI, we were thinking many years ago that who's going to be using donor sperm anymore, because IVF, can account for people who've had sperm problems, because many years ago, when men had very, very low sperm counts or, almost absent for the vast majority of those patients, they weren't obviously getting their wives pregnant, but they weren't able to conceive, and we didn't have a sperm source in order to help them. And then, IVF came out with a process called ICSI, where they could actually extract sperm either from the testicles or from the low amount in the ejaculate and actually insert it into the egg to actually improve or get pregnancies that way. And actually it works. But there are still subsets of patients out there who still need donor sperm. We still obviously do a lot of it. And particularly in the single female population where there's not a sperm source, or the lesbian population, it's very common to use donor sperm. Or even in heterosexual couples, if the male has a genetic problem, for example, you may not want to use his sperm, you may want to use a donor sperm. Or if the male has extremely poor morphology, and some of those men actually have gone through IVF and have very poor fertilization or poor embryo quality, we may have to use donor sperm in those individuals. So, it's still commonly used. In terms of actually doing it, if the patient we feel needs that, or if the patient, doesn't have a sperm source, obviously we're going to counsel them about, what is needed in this particular situation. So, the couple will undergo testing. If it's a couple, they'll be undergoing testing, on the female, obviously, to make sure that the female is a good candidate for insemination with donor sperm. If they're considering that, they'll have an HSG to make sure their tubes are normal. We'll make sure they have a good ovarian reserve. And they'll also have infectious disease testing as well as genetic testing. But in terms of also, the other thing that we also recommend in a couple is that they would also have psychological counseling, because especially in a couple where the male is not able to produce sperm and we're using donor sperm, the issues are going to be uncomfortable when the child grows up and he finds out, he's not, the father's not his actual biological father. Or if the child ever needs to be DNA tested, how do we deal with these kinds of things? And that's why we also recommend psychologists get involved, particularly in couples, heterosexual couples. Maybe less so in the lesbian population, but I still recommend psychological counseling in those people too. But in terms of choosing donor sperm, the couples have two choices, essentially. They could use anonymous donor sperm, which is from a sperm bank, an accredited FDA sperm bank, which is the only ones that we would be associated with, which means that the sperm has been thoroughly tested for any infectious diseases. It's been quarantined for the appropriate period of time. And, it's deemed safe because, the FDA is regulating this whole industry very much. And that's the first thing that they're concerned about. And many times, if you're choosing anonymous donor sperm from a sperm bank, you can see that this particular sperm is effective, that this particular person has kids with other people. You also get their genetic information, their medical information, their educational information, all that. And then some of those actually will allow you to participate in the donor registry. Like when the child turns 18, some of those people will allow you to contact that donor. So there is some contact. So there's sort of anonymous and yet not anonymous donors as far as sperm banks are concerned. The other type of sperm donor is a known sperm donor, where the couple or the woman would have a partner who's not married to her, but they want to use that sperm source. And, that's less commonly used these days. And that particular situation could get a little legally, difficult because, you have to have a legal agreement between the recipient of the donor sperm and the actual donor, so that everything's clear in terms of whether this person is going to have any parenting rights or not, or co-parenting rights, or whether this person has no contact at all, so that there's no legal entrapments later on, years from now. And that's really to protect the woman from being entangled in something like this. Now, and again, those donors, those known donors, are screened. Also, they have to have infectious disease testing, and once 7 days later, once after everything's tested and cleared, we're allowed to use them. But in some places, in some states, I believe the known donor sperm still has to be quarantined for 150 days, which definitively happens in the anonymous donor sperm banks. Those sperms are quarantined for 150 days. But in some states, I believe that still happens with known donors that come in. So that has to be taken into account sometimes. And you have to look at your state laws in terms of whether that's going to delay your insemination procedure if you're using a known donor. In terms of what we need to do, again, as I mentioned before, the woman will need to be screened medically, just kind of like almost what Ellen said in terms of infectious diseases, HIV, hepatitis, syphilis. They need an HSG to make sure the tubes are clear. They make sure that you have a good ovarian reserve, that you're a good candidate to use donor sperm. And also, we would recommend CMV testing. The virus, it's a type of a herpes virus called CMV, which a lot of people are exposed to, but some people aren't. And you may have antibodies. You may have antibodies to this virus, much like you may have antibodies to measles or any of those things. And the issue here is that when you select donor sperm, you should know what your CMV status is, because when you order donor sperm, your CMV status should match what yours is, essentially. So if you are CMV positive, you could actually use a CMV positive donor or even a CMV negative donor. And if you're CMV negative, you should use a CMV negative donor. Now, the danger of CMV is, it's probably a very, very low risk, but CMV is a virus that lays dormant in your body. It never dies or anything like that. It just lays there. So in terms of, and it could be spread through semen or blood products, etc. So that's why we make sure we know what your CMV status is before you get inseminated with any kind of donor sperm.
Does acute or chronic have anything to do? Is it like if it's a chronic exposure, does that make a difference whether it's acute or chronic?
Well, we look at, the IgG, just to make sure. And obviously, if she has an IgM, or if there's an IgM, or if we think there's an acute infection, we would delay that particular person until we see an IgG response. So it's a CMV IgG we're really looking for here, in terms of using the sperm eventually. Success rates of IUIs are depends how many times you do it. Really, it depends on what kind of candidate you really are. But under 35, if you have good ovarian reserve, good tubes, and you have reasonably good donor sperm, It may take many cycles, but it could certainly be successful. The problem is donor sperm is very expensive. Anonymous donor sperm. It's I think $600 or $800 a vial. I think, and typically, if you're going to try to make this successful, you may have to do up to 4, 5, 6 cycles. Some people do, and that's a fortune. And it may not work after that. Despite doing it that many times, it still may not work. I think they're quoting about a 49% success rate, maybe after 5 to 6 cycles. But typically, most people do 1 to 2, maybe 3 cycles, which gives you about a 30% chance, I would think. But at that point, after 2 or 3 cycles, most practices probably would say, "Listen, does it pay to continue to do this, or should you just go on to IVF, which has a more successful success rates in terms of also cryopreserving your fertility for later on, especially if you want multiple kids." And so, those sorts of things have to be discussed with the patient, how many cycles you want to do, and, how expensive it is, because a lot of times it's not covered. And that has to all be taken into account when you're sitting down with the patient initially. And
Do you recommend any sperm banks in particular, or is there one that you use a lot?
Well, we use the FDA accredited ones. We use, particularly the big ones, California, Cryobank, Seattle is one. I think we even have in-house donors from them. And Fairfax in Virginia, so the big ones typically, California, I think, has really, really good sperm. So does Seattle. They typically are the most success comes out of those places. And that's what we would recommend, is to use the anonymous donors. And, again, look at your finances, because all this is going to be expensive.
Very cool. Well, speaking of California, we have a special guest here. And I think that it's just very exciting because there's a lot of questions out there. And I think that, I like how she's referred to as the wedding planner for fertility. So Gail Anderson, she's the founder of Concierge. They're based in Northern California. And since 2006, Concierge has provided personalized services to help IVF patients navigate their third-party fertility journey. So they help actually clients from all over the world find, select, and match egg and sperm donors and gestational surrogates. So Gail is here to talk to us today about what kind of service she provides for couples and for women trying to conceive. So welcome, Gail.
Thank you. So I just thought I'd tell you how I got into this, which really is, my background is in counseling psychology. And I started out working within agencies and just was struck by when a woman was, faced with the idea that she can't go forward with her own eggs. Often they'll leave treatment completely. They sort of have to get to a place in the whole process of, mourning the loss of having a child that is genetically related to themselves. They go through the anger, all of the same stages that you go through with mourning any type of loss. And then they can get to a point, which can't be rushed, it just takes time. They get to a point where they can say, okay, I'm open to this. I want to have a child, and I'm okay that it's not genetically mine. Now, it's not a linear process. They might circle back and go through this again at some point. And one of the things that makes it easier for anyone to find a donor is when they can find someone that sort of looks like they fit into their family, someone that they can relate to. When they can feel like they kind of like this person, it's easier for them to be able to say, okay, I can do this. Because if they can't, then they're likely to feel like, the God, the universe, whatever, is not wanting them to have a child. So I found that they were struggling with this, and I thought there's got to be a better way, because no one agency, even, clinic, no matter how amazing any particular program may be, doesn't mean they're always going to have the right person for everyone who's looking. So we sort of call it, trying to find your tribe, finding someone that you can relate to, whether it's ethnic background. For some people, it's, just the way that the person looks. It could be their areas of interest. There are a lot of different things that will make someone feel like a connection to the donor so they can feel comfortable. I always say, don't sort of set your heart on one donor. in that when you're looking, you should plan a backup plan. And so what we actually do is we help the intended parents that come to us. They tell us their story. They talk to us about what's important to them. And then we recommend that as we're helping them to find candidates, that they think in terms of finding 3 to 5 possible candidates that they feel like could be a good choice for them. And the person who's going to make the decision in the long run, of course, the intended parents are going to decide who of the candidates they're looking at do they feel comfortable with. But it's the doctor that's going to say, this is a good candidate, because you need to also have someone who has good ovarian reserve, who can, come to your clinic, who you're able to get pregnant with, because those are the nuts and bolts of it, even though you want to be able to feel like you can feel comfortable with this person. So I also wanted to talk a little bit about gestational carriers too, because that's also an area that can be kind of a strange territory to get into when you find that you can't actually carry. Maybe you can use your own genetics, but you may not be able to carry. And there are a variety of reasons why that may occur, and I'm not going to get into that part of it. But the things that we always recommend that people look for when it comes to finding a gestational carrier are, we want to help them find someone who meets all of the ASRM guidelines, ideally has had easy pregnancies, easy deliveries, they have a healthy BMI, 30 or less is generally what we're going to be looking for, because if their BMIs get higher, just as Dr. Wood was saying, they may wind up having heart issues, they may wind up having gestational diabetes. There are a lot of things that can occur, and we want to make sure that this is safe for everyone involved. So we always look for people who have had easy pregnancies, easy deliveries. They've had no more than 5 pregnancies, generally speaking, and they could have one more, and that could be their surrogate journey. We don't want to see, I don't like to see more than 2 C-sections. ASRM guidelines will say 3, but the difference being, I'm not a reproductive endocrinologist, and most that I know are going to say they don't want to see more than 2. So those are some of the things that we're always going to be looking for. And beyond that, I think it's important just to find someone that you can have good communication with, that you can feel comfortable with. They're not going to necessarily be, like your next door neighbor, unless your next door neighbor is willing to carry for you, but that doesn't happen very often. So, you want to find someone who you feel like you can have good communication with, because it's a very interactive process. They're choosing you as much as you are choosing them. So it's something where, for us, before you ever have sort of a meeting, what we'll do is share a profile with you. You also have done like a Dear Surrogate letter where you're telling them about what your journey has been up to this point, and thanking them for their willingness to do this. But before we suggest you have a meeting, because you will always have a meeting, it's usually done on a video meeting to begin with, we're going to want to have your doctor review the medical records for that surrogate to make sure that they're healthy, and that there's nothing in their medical records that's going to raise a red flag and cause concerns that this is not going to be a successful pregnancy. Once that occurs, then you have your meeting, and it's usually a very nice little kind of give and take. It's a little bit like a first date. So it is, yes, a little bit awkward, but often it will be maybe you and your husband, or you and your partner, and the surrogate, and if she is married, her husband or partner, so that you can kind of get to know each other a little bit. There's usually someone on there from the agency who sort of is the moderator for this. But other important things to think about when it comes to surrogacy is you need to be working with a reproductive, someone who specializes in reproductive law, because you need to make sure that all of the legal aspects are covered, and that both the surrogate and the intended parents are being counseled on that level, so that there's no concerns later on, or if there's some sort of emergency that comes up, as to how that emergency situation will be handled. You want to handle all of those things before the process really starts.
Very nice. Well, I believe that this is very helpful, and I believe that we ask for questions to be submitted. So Dr. Wood, do you see any questions coming up on Instagram right now, or did you have any questions?
I haven't seen any questions specifically up on the feed. That's where like the audio gets when I turn the volume off on it.
Okay.
I have many questions go from the feed. We had one question earlier regarding, the genetics, and I tried to address that. And basically, again, it's your uterus. Your uterus can carry the baby, but the genetics and physical characteristics will be coming from the egg donor, which is why we try and match. And again, when we did this for years and years and years, I mean, I've done, egg donation. When I started my fellowship, we had a surrogacy program, gestational carriers, 1997. It's done far before that. But we had, a team of nurses, and basically what they would do is they would give us, a picture of you and your husband, and we would take that picture of you and your husband. And as we have recruiting our donors coming through, and this was, again, way pre-internet and frozen eggs and all this stuff, we would just bring the people in, and we would just kind of match them up and say, yeah, there's some, you got a double somewhere out there. I mean, and literally the babies that, we used to create from fresh donors that were, local, and sometimes they were from farther away, but they were local. I mean, amazing. I had this one couple probably 10 or 15 years ago, and a woman who had multiple miscarriages. She was 44, 45. We found her an egg donor. The patient had auburn hair. The donor had auburn hair, and she came back and she had twins. Twins. And she comes back into the office the one day to bring us these twin boys, and oh my gosh, the one little boy looked exactly like the mother. She's like, yes, people tell me that all the time. Like, it was just crazy.
I've seen that too. Yeah, that is true.
Well, we used to do. I mean, just even with a local area. So, a lot of times now, again, and I'm not sure how, Gail does it specifically. I mean, we do a lot of baby pictures and things like that. But, when we used to do it physically, we physically met the couple, and we physically were just constantly screening donors, you would, and we would always bring the donors in. So we'd have the recipient be monitored on one day, because we did the 2 cycles simultaneously. And then we'd have the donor come in on the next day. And sometimes, again, I wasn't a part of the process, and I'd go to retrieve the donor, and I'd look at the donor and go, oh my gosh, you look just like my patient. I mean, it's fascinating how close you can get. And now with, the internet and again, having the entire United States to kind of choose from. I mean, it's a lot easier now. And I'm sure Gail can touch on that, to kind of just find people that look like each other. But we did it in a very local basis, whether it was in Philadelphia or my practice, here in South Florida. But it is amazing how close you can get. Again, but the psychologist goes through, again, whether you want to disclose to the child, and there's a whole bunch of things involved in that from a psychological perspective. But really, when you're looking at making a family look alike, I mean, I've got babies back, and you would never know. They look just like the mom, or sometimes like the dad. But the family blends. You'd never really know that they had used either whether it was a donor sperm or donor eggs, and which is just fascinating how genetics work. It's pretty cool. But I think that's what a lot of the people who, and again, our nursing team right now is just very. We have a very large third-party nursing team in our practice, and again, they are just, with our 12 practitioners in our 6 offices. I mean, we have a very, very busy program. And again, the amount, as I started speaking about earlier, the amount of testing that we put the female recipient through to make sure that her pregnancy and she is going to be healthy through it is just incredibly tedious and time consuming. And our nursing team is devoting the bulk of their time to doing that. And again, so then we can get services from agencies like Donor Concierge for essentially what is a minimal fee compared to what all this costs, to expedite that process and to have such a nationwide database available. It's just really an amazing service, and especially getting your hand held through it. A lot of people have the time to look through the banks themselves and to go out and try and find their own surrogates. I had one patient probably 7 or 8 years ago, and I asked her, I said, where did you find your gestational carrier? And she told me Craigslist.
Wow.
It worked for her. I mean, it was just an interesting way. I just thought that was an interesting way, to find a gestational carrier. Some people are friends, but some people don't have anybody, and therefore they need to seek out agencies that have patients that are willing to do it.
I do have a question for anyone. It basically on our Instagram, it says, if I was to use a surrogate for my frozen embryo, would the cost be the same as a normal transfer?
Being pregnant. She actually offered to be a surrogate for a couple in Massachusetts, and she was working with a lawyer in an agency in Maryland. But it was a very interesting process just to go through that with her and to go through the contracts. And this was kind of very early into embryo testing and very early into single embryo transfer. And I said, no, you're not getting pregnant with twins. You've had 4 healthy pregnancies and you're not getting healthy with twins. And she's like, but they want me to take 2 embryos. And I'm like, no, don't let them put 2 embryos in. This is, oh gosh, I think her, and anyway, it didn't work out. And she got pregnant with her son at that time, and he's going to be 14. So it was a while ago, but it was just an interesting process to go through, and the patients who want to be surrogates. I mean, I think that's the cool thing as well. So when my sister wasn't able to become a surrogate for a couple, which she was really excited about doing, she decided to raise seeing eye dogs. And she's raised about 8 seeing eye dogs and gotten them paced with blind people. But that's a very, very intense process as well, and a very giving of yourself process. And then after she finished with the seeing eye dogs, she donated her kidney to a stranger. So there are people out there that are just really great people that just want to help others.
That was your sister?
It's really so, patients can't just do this, donate their eggs, donate their uterus, donate their bodies, donate 9 months, 10 months of their time, just for the compensation at the end. These are our donors. I haven't met a donor that I haven't liked. I haven't met a surrogate that I haven't liked and hasn't been excited about the process. I'm sure Gail can expound on that.
Awesome. Well, thank you very much. I'm not sure if Dr. Wood can hear us right now. I think she has to turn up her volume a little. There you go. We do have a question on our Instagram, and it's basically she's asking, if I was to use a surrogate for my frozen embryo, would the cost be the same as a normal transfer? So if anyone would like to take that question.
Address that.
Yeah, Dr. Gelman, would you like to address that, or?
Well, I think, we don't handle costs. We're not the financial people of the practice. I mean, that can definitely be answered for her. The financial team can reach out to her and give her a cost on that. But it would likely be a frozen embryo transfer. I mean, it wouldn't be any.
It is a frozen, right, but it's for a surrogate instead of the patient. So yeah. I would think they'd have to pay the surrogate's fees.
Yeah. Well, sure. Right. She's going to have to pay the surrogate. So that fee will be involved. So, I don't know exactly what that would cost, but that could be easily found out.
Okay. Yeah. So I guess that's good to check with the coordinators there, the IVF. Yeah. And see. And I know this is a huge subject. We could probably pick each one of these topics and go into another whole hour on each one of them. But I appreciate you guys listening and your questions. This particular patient or person on Instagram wants to know, this is a family member that is thinking about becoming a surrogate. So as far as that goes, and again, we don't know the cost, but have you guys seen any conflicts with family members being surrogates, or what is your experience with that?
So I'm going to answer that if you don't mind. It can work out very nicely, but it's something that whenever there is a situation where there's a family member that's willing to be a surrogate, everyone needs to get counseling, both individually and collectively. Because sometimes, you may have a sister who says she's willing to be a surrogate, and it could be that the other sister is not keen on that idea and maybe worried about conflicts, or vice versa. So you just want to make sure that they're both really comfortable with the whole idea. So they need to get counseling with a therapist that's really used to working with surrogates and intended parents, so that you can kind of make sure that they're coming together in a way that no one's kind of feeling a lot of pressure. And also, even if it's family, you really should have some contracts in place for how to handle certain things, because again, you don't want to get into a situation where, suppose the surrogate gets into a car accident, how are things going to be handled? So you have to kind of think through all those worst case scenarios that we hope will never happen and don't happen very often, but you just need to think through all of those things and decide, how you're going to handle it.
Very cool. Awesome. Well, are there any more questions out there? You can use this opportunity to ask away, and we'll be happy to answer them for you. And you could type them on Instagram at IVFMD. We're at FL Complete Wellness, or on Facebook, and also on Donor Concierge Instagram. So we're all any of those avenues. And if you happen to not think of the question right now because there's a lot of information, then maybe you can, remind us, you can message us, and then you can do that as well. So I think Dr. Wood is saying something here.
Immunology being a factor as far as immunologic infertility being a disease.
Mm-hmm.
And there is a lack of prospective randomized trials. So many practices do not believe in it. Some practices do. We do believe that this is a component in someone's, issues with fertility, and we do diagnose it frequently. The treatments that we offer are very, very easy. They're simple, but we have to know about the disease before we're able to treat it. So our practice treats it, but again, the lack of people, it being common practice is, we are taught to practice evidence-based medicine throughout our training, throughout our careers. And that's what, unfortunately, we're lacking, because it's very difficult to take, 100 women who you feel have, immunologic issues, and then 100 women who you feel have immunologic issues. And you say, hey, you guys wing it, and we're going to treat the rest of you. Let's just see what happens. And again, those studies are just really haven't been done. There has been one study looking at IVF failures and empirically treating without testing for immune treatments. And that actual study did come out with, after a failure, when the patient was treated immunologically, after the failure, the patients that were treated did have superior success rates. So that is one of the studies. However, there was no specific testing done. They were just empirically treated with treatment. So, and it's due to the lack of data. So if the studies were there, I think maybe more patients in the United States would maybe offered testing and treatment. But our practice does it, but many don't. So hopefully I answered that question.
Great. Awesome. Thank you. Okay, well, I think that we're wrapping up right now. We're about to wind down. And like I said, if we haven't answered your question tonight, please message us. You can DM me on Instagram or at IVFMD as well, and Donor Concierge. So I want to thank all of our guests tonight. I'm really excited that we got to talk about this. I hope things will get better for everyone in the coming weeks. Please join us tomorrow night as well on IVFMD on our Instagram and Florida Complete Wellness. And until then, I wish you guys the best. Please have a great night, and I look forward to talking with you guys.
Maybe we can have a follow-up on this in a week or so after we submit some questions. Maybe because of the blackout, we weren't getting many questions.
Yeah, we can try.
Maybe in a week we have a follow-up on this and answer the questions specifically.
Yeah, we'll try, definitely. And I know this is it's a heavy subject, so so I appreciate all of you guys' input, and I look forward to speaking with everyone soon. Dr. Wood, you had no other questions on Instagram for us to get to?
Center Foundation, don't have one. Yeah, I don't know. Are you aware, Gail, of any? We came across Egg Donation Center Foundation. Any grants for egg donation?
Grants, in other words, to help parents to be able to afford
Donor eggs.
Yes.
Yeah, there are a variety of programs out there that people can apply for. There's one called Baby Quest. There's the Cade Foundation. There's several that are out there that people can get help from.
Is there anything that has them kind of listed, or I'm just not familiar, with those services?
Yeah, that's a good question. I'm not sure if there's a specific site that lists all of them, but I can look into it.
Awesome. Yeah, maybe we can post these under our Facebook. That would be great. Yeah, resources.
Yeah, I'm happy to share that.
Right. There's another question not regards to surrogacy, but advice on InvCell. That's another Instagram live.
Tomorrow night.
I'd love to get into it. That's a whole like hour-long discussion in itself. And then, IVF, the prices we have our financial team that has incredibly competitive pricing, and there's depending on what type of services that you require, anything can range from $12,000 to $25,000 to $35,000. So, IVF, it depends. That's a very personally based type of thing as far as price, but I'd say low is 12.5, with highs much higher than that, depending on what exactly you need. I think that's about it. Again, average price of a surrogate.
Maybe Gail can answer that.
Sure. And I don't mean to be vague about this, but it really can vary quite a bit. Yeah. So I'd say anywhere from 100,000 to 150,000 or more, because it's not just like you're paying a surrogate. There are a lot of different things that are involved in that. So it's not a quick question or quick answer to be able to give you.
Had a uterus that was anomalous from DES exposure, and her sister, and they knew this throughout her life, and her sister carried her baby for the price of a new roof.
Oh, wow.
It's a good deal.
Okay, that's an interesting deal.
Yeah.
And then the funny version, they named the baby Penny, because she cost a pretty penny.
Oh.
That's what they did, a little girl.
Well, awesome. So thank you guys. It looks like we're wrapping up, and we're almost to
the questions.
we have one more.
I see the question here, but the InvCell, I think IVFMD has, I think in our live archives, I think we actually do have an InvCell discussion. If you go back on the IVFMD website, I'm not 100% sure, but I think one of our physicians has addressed InvCell and has done a live on that. But that was a whole hour itself. All right. So anyway, thank you so much. Gail, thank you so much for the information. And I think your services are incredible, and I think our patients will benefit from them tremendously as far as expediting and making their journeys easier. I really think that's where what you do comes in as such a huge benefit. Because again, we screen them, get them ready, make sure that they're healthy, and then if you can match them with a donor, hey, we'll get them pregnant.
Sounds great.
Thank you for the great.
Thanks, Dr. Gelman.
Thank you.
All right.
Thanks, guys.
Thank you guys.
Okay, good night.
Talk to you soon.
Good night.
Good night, everyone. Bye.